I will wait for a few more seconds to start the meeting before, because I think people are still coming in. I see that the number of participants is counting. So I suggest that we wait for 1 more minute. I see that currently there are no longer participants coming in, so I'm happy to welcome you to this third webinar in the series of webinars within around monitoring activities of Correlation European Harm Reduction Network. This webinar will focus on overdose prevention, and we have a very nice program for the webinar for around 1 hour. My name is Katrin Schiffer. I'm the director of Correlation European Harm Reduction Network, and I'm very happy to welcome you. So today I will give you a short introduction, and then we will have Rafaela Rigoni, my colleague, academic researcher for Correlation. She will present the main findings of the meeting of the monitoring report around overdose prevention, and then we will go into discussion with the panel members. So to give you just a short introduction on the monitoring, you might know that this is the third report we have been producing and we have been publishing around within the framework of correlation. One of the topics we always address is overdose prevention, and we have always thought it is an extremely important one. If you look also to the numbers, there is an increasing number of fatal overdoses, but also other overdoses. So EMCDDA report of 2020 reports around 5,800 people who have died. And most importantly, it is linked to polydrug use, and we see that this is due to mix of different kind of medicines, opioids, alcohol, and other kind of drugs. And we also know that harm reduction is a very extremely important element in the response towards overdose prevention, or in the area of overdose prevention. We talk about opioid substitution treatment, we talk about naloxone, we talk about drug consumption rooms, drug checking, and also to provide drug information. So for now, I would like to stop this introduction, and we'll give the word to Rafaela Rigoni. She will present the main outcomes of the monitoring, and then afterwards we come back with a panel. Rafaela, will you please come in?
Yes, thank you, Katrin. Good afternoon, everyone. I will try to share my presentation with you. I hope you can see this. Can you see it? Can you tell me? I don't see you anymore, but can you say, Katrin, if you are seeing?
Yes, it works.
Okay, perfect. Thanks. So what I will present is the data we collected for our monitoring, specifically on overdose prevention this year. So the major objective, just to give an overview for those who don't know, the major objective of the monitoring is to improve and complement the knowledge and information and harm reduction from the perspective of civil society organizations. So we do that in different cities and countries. Here you can see where our focal points are located. So for 2021, we had more than 100 organizations and individuals contributing we had 35 focal points from 34 cities. You can see in the map where they are. And most of our focal points, they are providing harm reduction services. So they are really on the ground, working directly with people who use drugs, sometimes also on advocacy activities or trainings. So our data focus very much on implementation, in this case, of overdose prevention activities. And apart from the focal points, we have more people contributing. So just to give you a bit of an idea, we have expert groups, and then we have an expert group on overdose prevention, which is helping us to frame what type of indicators, what type of questions we need to ask, and what type of data we need to collect. Our focal points will collect this data not only by themselves most of the times, but with collaborators, people, other services, service clients, other experts in their city. And we have the monitoring team who then does the analysis and writes the report, then with the revision of focal points and expert groups. So just to give you a brief idea, these are the themes that we had in the last year: harm reduction essentials, civil society involvement, hepatitis C, new drug trends, COVID, and then we will focus today on overdose prevention. So in terms of overdose prevention, what type of things we have looked at? So we have looked at guidelines, what is desirable regarding guidelines for overdose prevention. We looked into the context in which overdoses are occurring, which drugs are involved, the characteristics of overdoses. We looked into the state of trainings and campaigns for overdose prevention. We looked into the current state and needs regarding naloxone access and access to opioid agonist treatment. And we also looked into then desired improvements regarding overdose preventions from a civil society perspective. So to get into that, first to talk a bit about the context. So we asked people of our focal points, what type of overdoses they have heard of, like if the overdoses that they have heard of, which drugs they were involving. And you can see that in this graph that is comparing 2020 and 2021. And we see a bit of a trend. The numbers there are absolute numbers of focal points answering that. And we see a trend that is similar for both years, that heroin comes first. So mostly overdose are involving opioids, and heroin to a much lower extent fentanyl. In second place, it comes overdose related to stimulants. And then cocaine and crack cocaine are in 15% of the cases, and methamphetamine in 20%. And methamphetamine is the only one that we can see an increase from in how often focal points heard of overdoses with the drug between 2020 and 2021. The others there that you see are usually combinations of different drugs. So benzos with alcohol, ketamine with MDMA, ATS with methadone. And that's also a trend that polydrug use is often involved in overdoses people heard of. And then also what we see, we asked, so how was typically a victim of overdose? And usually then we see people were using alone, people were mixing drugs, people had no naloxone access, no drug checking or DCR access, so people don't know what they were using or how strong these things were, and had no access to life-saving services. Many times also people were homeless, and with that they had let's say precarious health, lack of sleep, lack of enough food, or then people also were on prison or treatment release and were not referred to any type of service, and then overdosed. We also asked whether the COVID pandemic has affected overdose rates, and we know from other sources that it has affected, as it was predicted that it would. And from the graph, you can see that our focal points have noticed a clear increase in overdose in their region during 2021 when compared to 2020. So in the first year, there was it was a bit half-half. People didn't know or they didn't see any increase. But in the second year, more people have seen, much more people have seen an increase. Not everyone, but many more. We also asked in terms of education about campaigns, awareness campaigns, and the graph there shows a comparison between overdose campaigns in focal point cities between 2020 and 2021. And what is really important to mention is that in 60% of our focal points mentioned that there were no campaigns whatsoever. We see that also a decrease in attention for campaigns if we compare 2021 with 2020. So most probably we think that's because due to the increased attention to prevention campaigns against COVID. And so in 2020, out of 35 cities, there were no OD prevention campaigns. In at least 14 cities, there were no overdose prevention campaigns in the last 2 years. Another point is that when campaigns occur, they mostly focus on traditional opioid use, and they leave aside stimulants, synthetic opioids, other new psychoactive substances, or combinations of drugs. And we also see that overdose prevention campaigns are missing for people who do not use opioids, but also family and friends of people who use drugs, because they are mostly available for harm reduction or medical staff or people who use opioids. We checked also the availability of naloxone. And this graph there compares who has access to naloxone in the cities where naloxone is available. So naloxone is available for 80% of, in this 80% of the cities of our focal points, but mostly available for medical staff. The good news is that if we compare 2020 and 2021, there is a clear increase into the availability of naloxone also to people who use drugs and their friends. And would we see, well, it is increasing. Before it was more available only injectable, and now also nasal is increasingly available. But what we see still that only 5 cities had naloxone available in pharmacies without prescription. And in only 3, naloxone was covered by health insurance. So there are still several challenges for people to access it. And also this is, of course, connected to lack of funding and support for naloxone. Then we also checked the availability and accessibility of opioid agonist treatment in the different cities. And it is widely available, except in one city or country, which is Russia, St. Petersburg in Russia, where still OAT is prohibited. In all the other places you see in the graph also what are the most available drugs, and that's methadone and buprenorphine, to a lower extent medical heroin or morphine. But yet, even though the availability is there for the vast majority, there are still several limiting factors for people to access treatment. And that's related to stigma of people who use drugs. That's related to limited hours that the program works. That is not very handy for people to go. Also related to the high threshold requirements of programs, that could be in terms of having people needing lots of documents, people needing to do urine tests or to be abstinent of certain drugs, or not being covered by insurance, and people don't have insurance, so the costs are too high for people to be able to get into treatment. Also, lack of prescribers in many cases, long waiting lists, and especially for young people, there's age restriction, which is a problem. So given that picture, we asked people, okay, what are the desired improvements then from civil society perspective that you would like to see to overdose prevention? And we see there in the graph that most people say there was no improvement. At least 2/3 of our focal points have seen no improvement of overdose prevention in the past year, although it occurred in some. But the desired improvements in any case is, well, first increasing the availability of naloxone, and then it should be available through peer distribution, available for friends and relatives of people who use drugs, available for take home, available at prison release, available at pharmacies, and free of charge. Also, access should not require a medical prescription. And all the legal barriers for administration of naloxone by non-medical staff and peers should be removed. And of course, funding should be provided. Many of those changes could be also applied to increase coverage of opioid agonist therapy, especially that it should be available for take home, should be available via outreach, and coverage needs to increase, especially in rural areas where it's not available yet. Also, people want supportive legislation. So, for instance, all these barriers to get naloxone, to get treatment should be removed. Meaningful involvement of people who use drugs is very important, and people should be much more included in overdose prevention programs. And this includes also funding more peer-led services that are doing overdose prevention. Also, what another desired improvement is increasing the provision of overdose prevention training. And this includes training family, friends of people who use drugs, care and law enforcement workers, people who are outside drug treatment settings, and training in overdose prevention for non-opioid drugs as well. Upscaling or setting up drug consumption rooms and drug checking services is also a desired improvement. In many places, the services do not exist, or they are not. They exist only one in the whole country in a pilot format. So this is something that is urgent in terms of advocacy as well. And finally, providing safe supply that could include heroin-assisted treatment and safe supply for non-opioid substances. Just to finalize, so following on those desired improvements, we also asked people, also suggested what ideal guidelines on overdose prevention should contain, and they go very much in line with all these desired improvements that I was just mentioning. I think it's worth mentioning that in at least 10 cities of our countries that focal points are, OD prevention is not yet mentioned in any guideline. But in the other, that's almost a third of all focal points. But also when the guidelines are existing, there is need for updating. And ideal guidelines for our focal points should contain provision of naloxone and take-home naloxone, low threshold access to treatment, continuous training, OD prevention for non-opioids, provision of DCRs, provision of first aid in case of overdose, and overdose risk assessment and screening. So this, in a nutshell, are the results we got for overdose for this year. You can find the whole report at this link there on our website. And if you have any doubts, you can always contact us. We have also some executive summaries translated in different languages. Well, thank you for listening, and I'm looking forward now to a good discussion.
Thank you, Rafaela, for this very comprehensive presentation. I forgot to tell in the beginning that participants to the meeting, to the webinar, if you have questions about the presentation, please share them in the question and answer section. and we will try to answer them during the panel discussion. And also if you would like to ask a question, which we can address then during the panel. So I now would like to invite the panel members to come up. We have 4 panel members. One is Aljona Kurbatova. She is the head of the Infectious Disease and Drug Abuse Prevention Department in Estonia. Happy she's here. We have Dirk Schiffer from the Deutsche AIDS-Hilfe. He has been involved with correlation also for a long time, and chairing the expert group on overdose prevention. We have Marios Aztemis. He is an activist and Euro Input member and works for Positive Action in Greece. And we have Adriana Curado. She's working for the Portuguese organization GATT. So Marios, you can also put on your video if you like. Perfect, there you are. So what I would like to ask you, what we don't want so much now is that you always go, I mean, your feedback should be based on your experience and your background, but what we actually want is that we collectively reflect on what Rafaela has just shared, and that you just tell us and share with us what you think about this information, about the added value of the monitoring, and also what it can contribute and complement in your eyes. So please go ahead. I can, if someone wants to talk first, that would be nice. Otherwise, I just pick someone.
I would like to jump in the conversation.
Perfect.
First of all, thanks for the invitation of the Correlation Network. Just a little bit of correction. The name is Positive Voice. It's a Greek association of people living with HIV. And also, I'm not exactly directly engaged with Euro Input, but with the European AIDS Treatment Group, the ATG. Anyways, that is something formal. So let's go now to the harsh reality. We have very disturbing evidence in Greece that we have skyrocketing mortality rates of people who use drugs. And one of the major causes is overdose deaths. So the question is why this is happening and why it is not officially recorded. Let's answer to this question. The why this is happening, because there is not enough naloxone provision. Naloxone is characterized as a medical act, so only doctors and nurses can use it. And there was a slight change in the Greek law right after the harm reduction conference in Prague. Remember that, so it was around December of 2021 that the law changed. And what exactly happened is that naloxone now can be used from the outrage and the street workers of the state programs, of the public programs, not the NGOs. So that is a problem, because naloxone cannot be provided to to the peer networks of people who use drugs, and to their families, and to their friends. So we have a big problem about that. The other thing is that there is not an organized campaign for overdose prevention. The only thing that is happening is that every August, on the International Overdose Awareness Day, the peer network of substance users, the Greek Users Union, makes a campaign of awareness. But this is not a campaign that is supported or engaged from the large organisms, from the public structures of the Greek state. So there is a big problem around that. The last thing I want to say is that these deaths are not being recorded or reflected in the national focal point. And why this is happening? Because there is a huge stigma. So the parents or the relatives of the deceased user convince the doctor who writes, the autopsy, that not to write that this is an overdose death, but to write this is a sudden heart failure or blah, blah, blah. Also, there is a lack of information of the directly affected community. about how to avoid overdose, even without naloxone. People are dying alone because they inject heroin of very questionable quality and they mix it with benzos, and they're all alone, and then they die alone. I lost, like, the last 40 days, I have lost 4 people that I knew personally. So there is a big problem, and we have to move a kind of awareness campaign that naloxone should be provided to the community and not to be characterized as a medical act. That was my contribution for now. It's very unpleasant, I know, but this is a fact that is not being written down officially. So we have to state it here that this is happening.
Yeah, I think that's an important point, and I think it's also one of the challenges we are facing, that if we look to what kind of data or information we can collect within our monitoring, I think it would be a difficult one to collect for us, because if the EMCDDA focal point cannot access the data, because it will be difficult, it will be impossible for us as well. But I think you're putting your finger on the open wound, and it's clearly something.
And something else, sorry, the last official data we have, it's before actually the pandemic. It refers to 2019. So we don't have any official information about what happened during the pandemic. But as a spear workers, we know what happened during the pandemic. And it was not good what happened.
Thanks. Someone else from the what how would you see, would you like to reflect on the reporting, monitoring? Aljona.
Yes, thank you for the invitation, and I think it's very important to have this information as comparison to perhaps more official reports by other organizations, and to maybe pick up on what has been also discussed by Marius, is that it's actually quite difficult to get timely official data on overdose deaths. Even we, being a part of governmental network, we have to wait months for official toxicology reports to be able to get confirmation, even though we know from the community that there are, for example, new synthetic opioids on the streets, and they have this very authentic experience, which basically demonstrates that the situation is shifting and that perhaps approaches need to be changed, and this change on the illegal drug market has to be taken into consideration. But even then, when we have this data from the community, we still have to wait months and months to get toxicology for confirmation, to be able to do something officially in terms of maybe scheduling new substances or perhaps doing official alerts, etc. And that creates, even for those governmental organizations who maybe are more proactive, quite a lot of frustration. And even then, it might be that we have, for example, data in Estonia from the last year, and we had that data in January. But then in June, the data was corrected, and we had 30% more cases which were confirmed. So essentially, we kind of always lagging behind the actual situation with official data. And unfortunately, a lot of decisions on how to adapt your policy within the country are based on official data and not on the data that we get from the community. And that makes me sad, because looking at what is expected, it's not something new. It's not something that has been it's something that we all know for a long time, and yet we haven't been able to deliver. And that makes me very sad, because this monitoring report is just another confirmation that we in our country also haven't been able to deliver the actual work that needs to be done.
And I think, Aljona, the fact is also that all countries are having different ways to collect this. This is, I think, also some point which was coming up in the question and answer section, right?
Yes.
Rafaela, can you, because I think you answered the question, can you
Yeah, well, what I answer, I can share what I answered, but what I answer is that we don't. That is indeed a problem, and that is indeed some discussions we had already with also our focal points working with the EMCDDA or ECDC, and that is a question. We did not check how countries formally report on overdose, so that's not what we did. What we do is very much local based qualitative data, small scale, based on the perceptions and the experiences that service providers have at the local level. So in that sense, you cannot say that this is you cannot generalize that for the whole country, but it's a local trend. So the way we collect data is that everyone answers the same type of questions on their impressions of overdose in their service and services around, and what they get from clients. And in that sense, it is a fast data, you can say that way, but it's a different type of data than the data from official sources that will give you numbers and estimations. That's not what we do.
Okay, thanks. Dirk, I saw that you before raised your hand, so I...
Yes, a few comments from my side. 1/3 of the European drug-related deaths came from Germany. In 21, we have the highest number of drug-related... Oops, sorry, my phone is ringing. We have the highest number of drug-related deaths since 20 years. We have about 1,830 drug-related deaths, mostly from opioids. And what we see is that, as you know, we have a lot of drug consumption rooms, that these rooms work to prevent drug-related deaths, because we didn't see one death in a million of when million of users use their substances in the drug consumption room, nothing worse happened. These things happened outside and alone at home. And we have an increase of naloxone and also an increase of drug consumption rooms. But all these harm reduction services, who are very important, are not in the position to stop the increase of the number of drug-related deaths. And so in my view, what we have to do is that an increase of harm reduction services is very important, because they do their job and support people who use drugs. But on the other hand, the situation of criminalization of people who use drugs is one trigger of drug-related death, that people hide their drug use, do it at home alone. And a lot of these drug-related deaths happens at home, and when people are alone. And so what we try to do is to get two things in harm reduction together, that drug checking is possible in drug consumption rooms. We have a law that this is not possible, but we try to change it now, that drug consumption rooms are in the position to do drug checking. And on the other hand, as you know, in Germany, we have a law we are working on a law of to legalize the use of cannabis via cannabis shops and for adults. And behind this this political action, we are discussing the decriminalization of people who use drugs when they buy their drugs for their own use, and that we got same amounts of drugs who are free and are not criminalized in all states. And it is a little bit disappointing that we see that harm reduction alone, as I said, we had a lot of increase in the last year. Drug consumption rooms, naloxone, drug checking is implemented, but all these services didn't stop the increase of drug-related death. And this is a little bit disappointing for us, but this is reality. And so we have to work on the frame of drug use in our countries and the criminalization. And in my view, only when we do both things, harm reduction services and decriminalization of drug use, we will see a stronger effects, positive effects of drug to minimize the number of drug-related deaths. Yeah.
Adriana, would you like to add also something?
Yeah, thank you very much for the invitation. It's a pleasure to be here to discuss the report and all the challenges we face. First, I would like to comment a bit the report and then other aspects. So I found very interesting that we have the city level here. I think it's a very good complement to the national and official reports we already have. Then, because many times the city level is the level where we can push and do more effective advocacy and even have more participation from the community or from the providers. So I think this is this is very interesting. Another thing that I found interesting, it was that the report is not only about the existing harm reduction services, but it's about what is needed, what is lacking. So this is also important. And as I totally share with Dirk and Marius and Aljona what they said, that is absolutely, we have still big issues with the availability of naloxone and other harm reduction interventions. So this is still an issue. Even when we have naloxone and we tick the box for the report, many times we know that the naloxone is there, but it's not in the hands of those who need it. So I think probably we need to in the future have a better picture of the coverage of these interventions. Also, I think also have here some COVID lessons for OAT, OST or OAT that show us that it is possible to have other rules in these programs, make them more accessible. And I think we need to keep pressure on this and to keep track of these changes, because we know that during the pandemic, some rules were made more easier for people to access and more autonomy and more choice for the users. But now I'm not sure if these changes that were good and were proven good and effective are being kept. So I think we need to keep pressure on this as well. To say that I totally agree that harm reduction alone and all the interventions is not enough. And I would add that decriminalization is also not enough. I think it's a step, but it's not enough. What we really need is the regulation of the markets and safe supply. I think we need to start pushing in this direction, because decriminalization is okay, it's better than nothing, but then we have the same problem. We keep the market irregulated. People don't know what they are using. Even if drug checking services are available, they are not available for everyone at all times. So the problem is that the market is in the, it's not in the hands of so it's in the hands of criminals, and this is a problem because people don't have any security when they buy or when they use drugs, that we don't know what is in there. So I think we this is a very difficult path that we have, but I think we have all the evidence showing that we need to start thinking about regulation. Then I would like to say also about some things on the methodology, and I find it interesting that from what I understood, this is the third report, so some improvements were made during the process. I was a bit curious about, okay, I understood that we have these expert groups that are defining the framework and the questionnaire. It was less clear the role of the focal points in this data collection development. And also I think it would be very, very good to have their feedback after they reported. What were the challenges, what can be improved, what is impossible, what data is impossible to get, and this was I could not find this information, but I'm sure you have some of these feedbacks that can be useful to improve the next report or the next questionnaire. So and because I many times I also have to report, and sometimes it's very difficult, and I don't know if the question was the question that was in the chat was related to this also, but some focal points, they may do it alone. Others, they just organize some type of meeting with other colleagues. So I think it's important to know the process, how people responded to this questionnaire. So for now, it's this.
Thanks, Adriana. I think you answered all the questions we wanted to ask already. That's very nice. I would like to give the last question to Rafaela. I'm sure you can be shortly.
Yeah, I wanted to, because I think Adriana made the very interesting points and things that are keeping us busy also definitely in the methodology. So just to start from the last thing, that indeed some focal points do this alone. Some focal points talk to 20, 30 other people. We always try to ask focal points to contact other people, not to respond alone. Not everyone does that, and we also understand we don't have so far yet. We don't have a system that we can fund focal points to do this work. So not everyone has the time to do it, but we try to keep transparent. So in every report, we will say who was the focal point and how many other people, and who were these people that they consulted. So the people that they acknowledged as contributing to the answers. So it's always there and it's to be found. Then about focal points involvement, that's a very good point. And from the beginning, focal points were involved in deciding the themes, in deciding the questions. There was a pilot phase in 2018 where only 5 countries were looked at, and at that point it was still countries. And focal point really helped with the whole construction. Because also of focal points feedback and feedback from others, that's why we made the switch from countries to cities, because focal points know much more about what's happening in the city. That's a better complement, as you mentioned, also to other reports that are already existing. So I would say focal point, and every year we have a meeting with focal points to see how the process is going, what type of questions, for instance, are difficult to get, don't make sense, what type of themes we should include. So we included harm reduction essential services. We included several questions because focal points asked us to do it. But we still think that that's not enough, and we are still trying to develop more. So we have this year also, we have another meeting, and we would like to check into possibilities where focal points can be more involved, more than mostly collecting data, but what else can focal points do? Also, we try to see with the focal points, how can we profit more from this report in terms of advocacy, local advocacy. And that's something that we are still, it's young, like it's the 3rd year, but we are still trying to develop more and more the involvement and integrate the feedback. So hopefully that answers, but thanks a lot.
Yeah, thanks for the response. As Adriana has already actually answered all the questions we have shared beforehand, I would like to give the opportunity to others also. Probably you can elaborate a little bit on what you think is the potential of the monitoring, of the key findings of the monitoring for to influence policies and also to inform advocacy at local level or national, and how in general you think we could improve the monitoring in general, but also in regard to overdose prevention. So I'm curious what you think, Dirk. I see your hand.
Yeah, only one sentence. The report is very important because we have more than one information from the government, and what we try to do in Germany, we can show good examples from other European countries, and they doing naloxone with other structures, free in pharmacies or something like that. And for this to put a little bit pressure on our local politicians, it's very important to have a report which is written from people who are working close to the field, and not only from the government, and that's very important for us. Yeah.
Just also to say very quick that in the report there is this kind of ideal guidelines for overdose prevention. We can actually translate that to each language, especially to places like Greece and other European countries that they don't have specific guidelines, official or unofficial, for overdose prevention. And probably correlation networks should support the international overdose awareness campaigns that we can do every August or whatever in local climax. That's my idea about that.
Aljona, you have ideas on that?
Yes, well, first of all, it's very interesting, and it has always been this way, that governments tend to be more influenced by international reports, even if the information in that report comes from the same local community organizations that they could listen in direct dialogue. So reports like this are a very good input on national policy level also, because also, it's in comparison to other countries. It's this comparison quite often also is the influence that is maybe needed to, or a pressure which is needed to motivate also local policymakers. I mean, it's sad again, but nobody wants to look bad when we talk about politicians. So, and if there is a source of inspiration on how to adapt some of the recommendations that would make you look less bad, not that necessarily they will be followed, but at least they are there. So it's more difficult to say that we don't know what we should do, because there is this evidence that this needs to be done, and the information that this evidence, that these recommendations are based on comes from your country also. So you cannot simply say that it's not valid to your country. And I think that they should be shared perhaps more widely also within the countries that reported the data for this report, because it seems that at least in our country, the last two reports haven't really reached all of the people who are involved in the drug policy work on the governmental level. So some have seen it, but I think that community is more knowledgeable about these reports than policymakers. And this is something that could be improved, how these reports are communicated, perhaps also with the focal points who have submitted the data to their national partners.
Okay. I mean, you're mentioning also here the cooperation with focal points, and I think that's an important one. And I'm not sure, I think in many countries there is a good cooperation with them, and there is also exchange, and I think many of the focal points also very much appreciate our data and information. But I'm not sure if you also have other examples or ideas on how this cooperation could be improved, and if there are other important stakeholders which actually can play a role here.
Well, it's easy to bring example of your own country, and one of the things that could be done is that the focal points contacts directly the national coordinator for drug policy. We being a small country, it should be feasible. I'm not sure whether the national coordinator actually knows that this. I know that national coordinator cooperates with the organization that is functioning as your focal point, but I'm pretty sure that the national coordinator doesn't know that that organization is your focal point, which is because they probably didn't think of specifying this. So there are small things like that, and they will be different in different countries, I guess, based on the situation, which is and how open the dialogue between different partners is, whether there's opposition to some ideas or some things are simply left unsaid because people think that they should be self-evident, but they are not.
Yeah, I think that's very true. And I think in general, when I listen to all these things, and we had this focal point meeting last year in Prague, and there are fantastic ideas on how we can improve the monitoring. And I think in general, we already implemented some of these suggestions. The problem is that if we would implement all kinds of suggestions, the workload for focal points would increase too much. And we have these kind of limitations that we need to be aware that we cannot support our focal points in a financial way. So there is a lack of resources in this way, which we need to acknowledge, and we don't want to over-ask our focal points. Rafaela, you want to say some concluding words or some words on what you think you would like to improve on, or where you think we should go in the next years?
Yeah, I think, I mean, a lot of things I think have been said, and it's such a nice thing to have these meetings, to have all these ideas. It's always good to see how other people think about it. And I think it's very much in line with what you have been saying. And for me, I think ideally we would involve focal points more and more. We would involve them in organizing local advocacy based on these results. And ideally, we would have funding from focal points to do that. This is something we are still trying to figure out how could we get there. But I think that would be a way that I would like to go as a team. I think we agree on that too. And also we are working more on defining really indicators. So we have been doing that, but I think we are getting to a point now with the third year that we can go more in depth into that. What are the things that we really want to look at that are important for civil society? So not only the indicators that are, out there for the national reports or international reports, but what do we value as important and what do we want as civil society to be out there? So I think this would be for me some directions to go.
Yeah. I think that said, I totally agree. I think there are many ideas. We will hopefully be able to discuss that in November in Athens during the member meeting. You will receive an email on that in due time. But in general, I think looking back to the last years, I think we can be very proud on what we have achieved together with all of you and the focal points and the experts who have contributed. And it's definitely work in progress. And we shouldn't forget that everyone is struggling in collecting data and information. Also, the EMCDDA, which has so much more resources available, is struggling with certain problems, meaning that we definitely should be aware of that and we should try to overcome the challenges in which we are, but we should also be proud and happy with what we can do. And as a final one, what I think what could be a potential way forward is that we try to address and link potential national projects to what we are doing anyway in the monitoring, and meanings if you have a certain project in the area of overdose prevention, in the area of hepatitis C, let's see if there are ways in one way or the other how we can include that or address that, because I believe that could increase the impact of your work and activities, as it can also improve ours. So I think we are exactly 1 hour. We have talked now, and I would like to thank all the panel members and Rafaela for being here and for contributing, all the participants for listening, and I hope you will join the next one, which will be after the summer break, I guess. And I wish you a lovely summer until then.
Thanks a lot.
Bye-bye to everyone.
Thank you.
Thank you very much.
Thank you. Bye.